anatomies, as we all know, our arteries. So we have our arteries, our veins, right? So for our arteries, we have the intima, the media, and adventitia. So these are three concentric layers of tissues that are composing your arteries, and they have different functions, as we all know. So for your the arteries between the intima and the media, you have your internal elastic membrane. Okay, so those layers, the three layers, have layers or membranes between them. So between the intima and the media, you have your internal elastic, and between the media and the adventitia, you have your external elastic membrane. So again, tunica intima, tunica media, and tunica adventitia. So first, we discuss the tunica intima. So in this illustration, you can see the different layers. With the inside the box would be your tunica intima. So this is the innermost layer. So this is a single continuous lining of endothelial cells. For okay. Okay, so it's a single continuous lining of endothelial cells. It surrounds the lumen of all our blood vessels. So it produces the prothrombotic molecules. It modulates blood flow and vascular reactivity, and it regulates the immune and inflammatory reactions. So in this layer, it synthesizes the regulator of thrombosis, such as prostacyclin, plasminogen activator, your heparin-like molecules. So it is remarkable for metabolic properties. So this layer, it regulates the immune reaction, the inflammatory reaction. So if there are changes in this layer, so that's when the reaction starts. Okay, so you have your later we will discuss the atheroma formation. So if there are breaks or there are any changes, then there is a cascade of reaction forming that atheroma. Okay. So here, I hope you guys can see. It's very small, but so if there are chronic endothelial injuries, so the changes that I've mentioned, the injuries, so hyperlipidemia, hypertension, smoking, homocysteine, hemodynamic factors, the toxins, the viruses, so those cause the damage. So that there would be a response to that injury. So there will be endothelial dysfunction. So maybe you will have the increased permeability, the leukocyte adhesions, and all those things. So you can have your platelets and monocytes there. Then after that, you have your macrophage activation, smooth muscle recruitment. That will be in the next layer. Then the next would be the macrophages and smooth muscle cells will engulf the lipids that are formed, and there will be proliferation. So collagen and outer extracellular matrix deposition would be in that area of damage. Then you will have your extracellular lipids. So there is a proliferation of the smooth muscle cells in the extracellular matrix that breaches the endothelial lining. So that would be the damage. Then it contains fibrous cap of smooth muscles that overlaps the following. So there will be a necrotic lipid-rich core, vascular cells, immune cells, and prothrombic molecules. So those are the components of your the atheroma complex. Okay. So again, Atheroma formation begins in the intima, as we all know. So you will have your circulating lipoproteins. Usually it's the LDL, your low density lipoproteins, which are exposed to proteoglycans from your extracellular matrix. So they undergo oxidative modifications, which triggers the local inflammatory responses, as we have seen earlier with the macrophages, your platelets, and everything. And it attracts mononuclear phagocytes. Then in the intima, your phagocytes will mature into macrophages in the image that you have seen. So those macrophages would ingest your lipids and it becomes full cells that develop into fatty streaks. So those fatty streaks are this atheroma complex that would stay in that particular layer of your blood vessel. So the more damage that it causes, the more deposition of your atheroma, and soon there would be blockage in the future if you don't treat it. So next would be your tunica media, your second layer. So this tunica media is composed of smooth muscle cells, and it dilates and constricts to accommodate blood pressure and blood flow. Okay, so it is bounded by your internal and external elastic lamellae, right? Because between the tunica intima and tunica media, you have your internal elastic membrane, and between this and the outer layer would be your external. So perfused by small arterioles called your vasa vasorum. Then, after the tunica media, you have your tunica adventitia. So it is an outer layer of your artery. So it is the connective tissue containing nerve fibers and your vasa vasorum. So in this area, here. So you have your nerve fibers, you have your arterioles, and other structures. So that it will be the outer layer. Okay, so those are the three layers of your tissue. So now we go to arterial branching. So arteries must respond to the variations in cardiac outputs in our body, right? So if you review, or if we review our anatomy, there would be a difference in anatomy, different size. So from our heart, the greatest pressure, right, of blood, it goes out. So the arteries receiving it will be the larger arteries, the stronger arteries. Then as it goes through our body, it becomes smaller and smaller because the pressure also goes down, right? Okay. So the anatomy and the size vary according to their distance from the heart. So the aorta and its immediate branches are large and highly elastic. Okay. So aorta, then it goes into the medium-sized muscular arteries as the pressure goes down. Please come in. So you have your coronary and your renal arteries further down, then divided into smaller arteries. So smaller arteries, remember, small arteries are less than 2 millimeter, and the smallest would be the smaller ones would be arterioles, which are less than 20 to 100 microns. Okay, then the smallest would be your capillaries. So capillaries are usually 7 to 8 microns. Okay, remember the sizes. Maybe it will come out. Maybe. So again, small arteries less than 2 millimeter. So millimeter, small arterioles will be 20 to 100 microns, and capillaries 7 to 8. Okay. All right. So arterial branching. So if a major artery is obstructed, what happens? What does the body do? It finds another way. So anastomosis would happen. Okay. So anastomosis between branching networks of smaller arteries increase in size over time. So even though there is a single supply of blood, there are still small anastomosis happening. So if that supply would decrease or be blocked, the smaller ones would compensate, become larger, and the blood flow to that particular organ would be through the anastomosis. Okay? So it forms collateral circulation that perfuses structures distal to the occlusion. So our body is prepared for possible obstruction. Okay. So now we go to arterial pulses. So arterial pulses are palpable in arteries lying close to the body surface. So pulses in the arms and in the hands, as seen in this picture, you have your brachial artery, your radial artery, and your ulnar artery. So later on, we will be discussing this again in the techniques of examination. But I want everyone here present to try to locate your different pulses. So can you do that now? Try to locate your brachial artery. So it is in the bend of the elbow, just medial to the biceps tendon. Okay? So try to, I know it's difficult, but you can still feel it. Okay? So it is at the bend of the elbow, just medial to your biceps tendon. And your radial artery on the lateral flexor surface of your wrist, of the forearm, but the pulsations are usually at the wrist. Okay. Then your ulnar artery located in the medial flexor surface. Then after that, we go to pulses in the abdomen. So in the abdomen, you locate the pulsation of the aorta and the epigastrium. Then, not applicable are the three important deeper branches of that of the aorta. So you have your celiac trunk, your superior mesenteric artery, and your inferior mesenteric artery. So they perfuse important organs of the abdominal cavity. So if you can see the picture, you have your celiac, you have your superior, and you have your inferior. So they supply different areas. Okay, which is very important because we should know which areas they supply.
It's electron organ, superior mesenteric artery, midgut, and inferior mesenteric artery, end.
Yes, very good. But you should know what organs are in that area. Okay. So, for what? Okay. I'm sorry I wasn't able to include this, but for your celiac trunk, the foregut, right? So what organs are
Stomach, liver, spleen, pancreas, upper part.
okay? Very good. So you have your number one esophagus. For what? Okay, esophagus. You have your stomach. Very good. In the lower part, you have your proximal duodenum included. You have your liver. So gallbladder, pancreas, and spleen. So don't miss out on anything because in the exam, we might just give you just the spleen, or we might just give you just the liver. So not everything would be listed. Okay. So for gut, you have your esophagus, your stomach, your proximal duodenum, your liver, your gallbladder, your pancreas, and your spleen. Superior mesenteric. So that's the very large blood vessel going to the right side, lower area, so midgut. So you have your small intestine, composing of your duodenum, ileum, your cecum. You have your large intestine, which composed of your ascending, and your transverse, okay, and your right splenic flexure, the curve. Then you have your hindgut for the inferior mesenteric. So that will be the remaining parts, the descending, the sigmoid, and your rectal. All right. Then we go to the pulses of the legs. So pulses of the legs are shown in this figure, figure 12-5. So these pulsations, you should know, especially when we assess patients with um, peripheral vascular diseases, diabetic patients. Those patients can have diminished pulses in the extremities, right? So you have your femoral artery. So just below the inguinal ligament, midway between the anterior superior iliac spine and the location, anterior superior iliac spine, your symphysis pubis, inguinal ligament, so it's between or it's midway from those landmarks. So when you assess your patient, probably patient will be supine. Try to locate those bony prominences. Then try to slowly palpate for that area. Okay. Next, you have your popliteal artery. So it will be an extension of the femoral artery. It passes medially behind the femur and palpable just behind the knee. Okay, so from the femoral artery, okay, you go down, then it would be the posterior portion of your leg. Right. So later we will discuss how to palpate that. The popliteal artery divides into two arteries perfusing the lower leg and foot. So this would be your dorsalis pedis artery. So this would be on the dorsum of the foot, just lateral to the extensor tendon of the big toe. Then you have your posterior tibial artery. It lies behind the medial malleolus of your ankle. So this would be there would be an arc interconnecting between two chief arterial branches, protects the circulation of the foot. So even though there will be damage in one area, there would be still other branches to supply that foot. So there is one thing written on the book where even though there is rich collateral network that protects the three branches against hypoperfusion in that area of your leg, occlusion of your mesenteric arteries can still result in bowel ischemia and infarction. So I will not show it again. In the book, you can see that your mesenteric arteries supply a lot of organs. So if still there are occlusions in that area, still you will have bowel ischemia and infarction. That's why it's a medical emergency. So patient needs to go to surgery right away if there is damage to that area because it's a major vessel. Okay. So any questions so far? Anatomy review is okay? Yes?
So, in the popliteal artery divided into anterior tibial and posterior tibial. And anterior tibial, when it crosses the malleolus,
Yes.
then we call the dorsalis pedis.
Yes.
That is nothing like
There is what?
I told popliteal artery
Oh, yeah.
divided into anterior tibial artery and posterior tibial artery.
Mm-hmm.
When the anterior tibial artery crosses the malleolus, then we can call dorsalis pedis.
Yes, it's in this part. Yeah. It's not discussed. Yeah, it's not discussed
Just
fully.
divided.
Yeah. So just the main. That's just the major arteries. But still, you should just remember the major one because that would be the more superior one that we can palpate during anatomy. capacity because they tend to distend and to flex depending on the load of blood that will be pulled into that area. So two-thirds of circulating blood flow would be located in your veins. The smaller ones, or the smallest veins would be your venules. So they drain capillary beds and they form interconnecting venous plexuses. So again, three concentric layers. So the venous intima or tunica intima consists of thrombogenic endothelium protruding into the lumen or unidirectional valves that promote venous return to the heart. So this is sorry. So it has a different function than your arteries. So in your arteries, it's more of the immune responses. It responds to damage, responds to thrombosis. Then for this part, it's more on the its function. Its function is to return blood to your circulation. So it has valves. So it has a non-thrombogenic endothelium, and it has a protruding area in the lumen of unidirectional valves that promote venous return to the heart. Okay. Then your media, it contains circumferential rings of elastic tissue and smooth muscle. So it helps in accommodating the blood that goes into that layer of vein. Okay, so change in caliber in response to minor changes in venous pressure. So the higher the pressure, the more it distends. The lower pressure, it contracts again. Then your adventitia. So thicker than the tunica media, consists of collagen fibers and networks of elastic fibers. So you can see it here. Elastic fibers, smooth muscles, collagens, macrophages, fibroblasts, and all those things in the outer. Same as the arteries, just the different thickness. Okay. Okay. So venous drainage, it would be confusing. It would be quite confusing, but let's just try to follow. So veins from the arms, upper trunk, head, and neck would drain into your superior vena cava. Okay, so it's a simplified form. So remember, arms, upper trunk, head, and neck would drain into your superior vena cava, which empties into your right atrium. Okay, so this would be the end part. So from all those things, still this would be the end. Veins from the abdominal viscera, lower trunk, and legs drain into your inferior vena cava, except, so there is an exception. For circulations through the liver, there would be another vein that would accept that. So the portal vein at the confluence of the nutrient-rich superior mesenteric and splenic veins would supply 75% of the blood flow to the liver, supplemented by oxygenated blood from the hepatic artery. So blood from these vessels flow into the hepatic sinusoids, then drain into three large hepatic veins that empty into your inferior vena cava. Then after that, the inferior vena cava will drain into the right atrium. Okay. So because of their weaker wall structure, the leg veins are susceptible to irregular dilation, compression, ulceration, and invasion by tumors and warrant special attention. So that is why the lower leg veins or the deeper veins would have more problems compared to the upper part of the body. So you will have the ulcerations, maybe the varicose veins because of the structures that or the composition of their structure. So again, portal vein. Again, there you would have your superior mesenteric vein and the splenic vein, 75% of blood flow to the liver, and it is supplemented by oxygenated blood from the hepatic artery. Okay, susceptible to irregular dilatation, compression, ulceration, invasion by tumors, and it would warrant special attentions, your leg veins. Okay. Deep and superficial venous systems of the leg. So the deep veins of the leg carry approximately 90% of the venous return from the lower extremity. They are well supported by surrounding tissues. So your superficial veins are subcutaneous with relatively poor tissue perfusion. So the different superficial venous system of the legs would include your great saphenous vein. Okay. So the great saphenous vein originates in the dorsum of the foot, passes just anterior to the medial malleolus, and continues up to the medial aspect of the leg. Usually, this would be the more visible one because of its location. So it joins the femoral vein of the deep venous system below the inguinal ligament. Okay, just try to imagine from your anatomy. You didn't have chance to do the cadaver, right? How about the dummy or the one? No, online. Yeah. Sorry, I forgot. But still, if you go into our social media, not social media, but different YouTube, different sites, you can have the three-dimensional representation of the human anatomy. Then you can some even have like veins. They discuss particularly veins, arteries, muscles, tendons, and everything. So if you just follow those formats, you can still imagine these ones. Then you can do this if you have friends or families that you can examine. Then you will be able to locate or at least have an idea how to locate this. Okay. So next would be your small saphenous vein. So it begins in the lateral side of the foot, then passes upward along the posterior calf and joins the deep venous system in the popliteal fossa. So lesions in this space are not usually associated with palpable inguinal lymph nodes. Okay. You have your anastomotic veins. So these anastomotic veins connect the two saphenous veins and are readily visible when they are dilated. So bridging or perforating veins connect the superficial system with the deep system. So you have your this image here to illustrate that. Okay. So when competent, the one-way valve of the deep superficial and perforating veins propel blood towards the heart, preventing pooling, venous stasis, and backward flow of your blood. So contraction of the calf muscles during walking serves as a venous pump and also propels blood upward against gravity. So that's why, so for some people, just sitting down or just at the bed, so you will have your edema, pooling, possible ulcerations in the future because of the diminished blood flow back to the heart. Okay, so those patients who are paraplegics, right? So they can't move. That's why you still have to do exercises to those patients. You have to move their ankles, move their legs to aid also in the blood flow, not only in developing the muscles, but also to aid the blood flow towards or back to the heart. Okay, so your deep venous system of the leg, they carry approximately 90% of the venous return from the lower extremities and well supported by your surrounding tissues. So you have your external iliac vein, your femoral, your deep veins of the thigh, popliteal vein, posterior tibial, fibular, and anterior tibial. So those are the deep venous systems of the leg, which we cannot really examine because of their location. But it's helpful to know that most of the blood will be there, and for the superficial, at least we can know if they are patent or they are still functioning when we do examination. Okay, so we've discussed the arteries, the veins. Now we go to the lymphatic system. So the lymphatic system is an extensive vascular network that drains lymph fluid from body tissues and returns it to your venous circulation. Networks of lymphatic capillaries, lymphatic plexuses, originate in the extracellular spaces where the capillaries collect tissue fluids, plasma protein cells, and cellular debris via their endothelium, their porous endothelium. Okay. So the lymphatic capillaries continue centrally as thin vascular channels, then as collecting ducts and empty into the major veins of the neck. Okay, as you can see in the illustration, the green ones. So we will discuss the different areas that they drain. First would be your right lymphatics. So your right lymphatic drain fluid from the right side of the head, neck, thorax, and right upper limb, and empty into the junction of the right internal jugular and right subclavian vein. You just follow the drainage. Then you have your thoracic duct. So for the thoracic duct, it collects lymph fluid from the rest of the body and empties into the junction of your left internal jugular and left subclavian vein. So lymph fluid transported through these channels are filtered through lymph nodes interposed along the way. So that's the function of your lymph nodes. So again, your right lymphatic duct. So right side of the head, neck, thorax, right upper limb, and it empties into your right internal jugular and right subclavian. Your thoracic duct empties into the junction of your left internal jugular and left subclavian. Okay. Then the filters. So your lymph nodes. Lymph nodes are round, oval, or bean-shaped structures that vary in size according to their location. So some lymph nodes, like your very auricular nodes, if they are palpable, are typically small because of their location. Then some are larger. Example in the axilla, in the inguinal area, so more palpable. In the body. This, so lymph nodes will be enlarged. If you have infection in the hand, axillary nodes would be inflamed. Okay. So only the superficial lymph nodes are accessible to physical examination, as we all know, and this includes the cervical nodes, axillary nodes, and nodes of the arms and legs. Okay. So again, only lymphatics of the superficial lymph nodes are the only ones accessible to physical exam. So they would include the cervical nodes, axillary nodes, and the arms and legs. Okay. Okay, so first we discussed the axillary lymph nodes. So the axillary lymph nodes would drain most of the arm. Okay, so try to locate that. So lateral and central axillary nodes. But we should take note also that lymphatics from the ulnar surface of the forearm, hand, little and ring finger, and adjacent surface of the middle finger drain first into your epitrochlear nodes. Okay, so before they drain to their axillary, they are filtered by your epitrochlear nodes. So they are located on the medial surface of the arm, approximately 3 centimeter above the elbow. Lymphatics from the rest of the arm drain primarily into the axillary nodes. So some lymph fluid may go directly to the infraclavicular nodes also. But remember, ulnar surface of the forearm, little and ring finger, and adjacent surface of the middle finger. Maybe again it will come out in the exam. Maybe. Okay. Nodes. So lymphatics from the rest of the arm are primarily drained. Then superficial lymph nodes are the only ones accessible to physical examination. So there are two groups. You have your horizontal group and your vertical group. This would be for the lower limb or lower extremities. So we will discuss first the horizontal group. So lies in a chain high in the anterior thigh but below the inguinal ligament. So it drains the following: superficial portions of the lower abdomen and buttocks, the external genitalia but not the testis, the anal canal, the perianal area, and the lower vagina. Okay, remember the areas that they are draining. Okay, superficial portions of the lower abdomen and buttock, external genitalia, except the testis, anal canal, perianal area, and in females, the lower part of the vagina. For the vertical group, so it clusters near the upper part of the saphenous vein and drains a corresponding region of the leg. So in contrast, the lymphatics from the portion of the leg drained by small saphenous vein. So the heel and outer aspect of the foot are drained by the small saphenous vein, and they join the deep system at the level of the popliteal surface. Sorry, I don't have the illustration, but lymphatics from the portion of the leg drained by the small saphenous vein would join the deep system at the level of the popliteal surface. And the lesion in this space are not usually associated with palpable inguinal nodes. So usually in that area, the lower leg. Mostly, if you want to palpate for infection, the nodes would be from the arm, cilia, and the inguinal area. Okay. So anatomy is done. Let's take a part of fissure. So what is transcapillary fluid exchange? So blood circulates from the arteries to veins through capillary beds, as we all know. So traditionally, fluid shifts between the plasma in the intravascular space and the tissue interstitial space. And we have the Starling law to describe those movements. Okay. So Starling proposed that outward filtration at the arteriolar end of the capillary due to hydrostatic and interstitial colloid oncotic pressure, and the inward resorption of the venous end of the capillary due to the colloid osmotic pressure from the plasma protein. I hope you remember your physiology. So higher pressure, lower pressure. So from the arteries, the veins will be pulling. So there will be exchange of fluids or pressure. So again, outward filtration of the arteriolar end of the capillary due to your hydrostatic and interstitial colloid oncotic pressure. So pulling out. Then inward resorption, pulling in because of your colloid osmotic pressure from plasma proteins. So because of the concentration. That would be Starling's law. Okay. So recent studies have demonstrated greater complexity in capillary dynamics and relationships between your endothelial capillary lining and the interstitium and lymphatic drainage. But basically, Starling's law still applies, but there are more complex from different areas of the body. So net filtration appears to continue throughout the capillary, regulated in part by capillary endothelial glycocalyx layer that affects intravascular volume and net filtration. So capillary endothelial glycocalyx layer affects the filtration. Interstitial oncotic pressure is lesser than your plasma oncotic pressure. That's why you can have this net filtration through the fluid exchange. Okay, there's tissue. So the interstitium is more than a reservoir for plasma ultrafiltrate. It is a complex system of fluid containing albumin. So this is a gel consisting of glycosaminoglycan molecules and collagen. So capillary transendothelial filtration has been found to be significantly less than previously understood, and most filtered fluids return to the circulation not as fluid resorbed at the venous end of the capillaries, but as lymph. So more than it's not it's more of the lymph, not the venous return in the capillaries. So the kidney, sorry. Okay. The kidney also plays a role in retention of sodium and water when plasma volume goes down, and much of this fluid enters the interstitial space and appears clinically as edema. So if there is no proper circulation, that's why patient would go into or will have edema. So how does edema develop? Okay. So if you have increased plasma volume from sodium retention, altered capillary dynamics resulting in net filtration, inadequate removal of filtered lymph fluids, lymphatic or venous obstruction, and if you have increased capillary permeability, then you will have edema. So if you have those factors, then you will have pooling of your fluids in that particular area, mostly our feet, because of the difficulty of bringing that fluid back to our circulation. Right? So again, increased plasma volume from retention of sodium, altered capillary dynamics resulting in net filtration, inadequate removal of filtered lymph fluid, and increased capillary permeability. So your capillaries would be sending fluid to the different tissues, not in the circulation. Okay, that's why you have edema. Okay. Um, so in my slides, I will just discuss a little about edema. So you have the types of peripheral edema. This would be in the later part of the book. If you're reading your ebooks, this would be in the later part. Okay. So types of peripheral edema, you have your pitting edema. These are soft, bilateral, palpable swelling. It occurs during prolonged standing or prolonged sitting, meaning you have inactivity. Your legs will not be contracting. Your muscles are not helping circulation. So it occurs in diseases like heart failure, nephrotic syndrome, cirrhosis, or malnutrition. So basically, heart failure, circulation is bad already. Nephrotic syndrome, kidneys, circulation also is bad. Cirrhosis, malnutrition, you'll have less albumin, less other factors to help in resorption and in circulation also. Then you have your chronic venous insufficiency. Again, you will have this would be soft, pitting on pressure, occasionally bilateral. You have changes like brownie changes, skin thickening near the ankle. For chronic cases, you have ulcerations already, brownish pigmentations. So obstruction of the lower extremity circulation, incompetent valves in the deep venous system. Again, because of poor circulation, pooling of your fluids, you can have the these changes in the skin. Then lymphedema, initially soft and pitting, then it becomes hard and non-pitting. So skin is markedly thickened. Ulcerations would be rare, no pigmentations, and usually bilateral feet and toes for lymphedema. Okay, so that's just a taste of the pathologies that we could encounter if we have patients with poor circulation. Okay. So now we go to health history. What should we ask our patients when we do history taking? The arms or legs. So meaning patient have numbness or pain. Then intermittent claudications, cold, numbness, pallor in the legs, hair loss. Why hair loss? Because poor circulation would cut off the nutrients, no growth in those tissues. So basically, you'll have hair loss, swelling in the calves, legs, or feet. Again, circulation is poor. Color changes in fingertips, toes, especially in cold weather. So in cold weather, circulation changes. It would be more on the core. Extremities would be lesser circulation, right? So we can see this in cold areas. We have frostbites. Then swelling with redness or tenderness in different areas of the body, extremities. So meaning circulation is disrupted. So first, we will discuss for your peripheral arterial disease. So as noted, PAD refers to stenotic, occlusive, and aneurysmal disease of the abdominal aorta. Its mesenteric and renal branches and the arteries of the lower extremities, exclusive of your coronary arteries. So pain. Okay. Pain in the extremities can also arise from skin, musculoskeletal system, or nervous system. It may also be referred like the pain of myocardial infarction that radiates to the left arm. So we have to distinguish between the pain that the patient is feeling. Okay, that's why we also have to know how to describe the pain in MI or myocardial infarction and the other causes of pain in the trunk. So we'll ask our patients. So ask about abdominal, flank, or back pains, especially in smokers. So smokers, as we all know, are at high risk for developing this disease. Then unusual constipation or distension. Inquire about urinary retention, difficulty voiding, or renal colic. You have to ask if there are persisting abdominal pain. Ask about any related food fear and weight loss or dark stools. So these symptoms suggest mesenteric ischemia from arterial embolism, arterial or venous thrombosis, bowel volvulus or strangulation, hypoperfusion. Also, failure to detect acute symptoms can result in bowel necrosis and even death. That's why I've mentioned earlier that it is a medical emergency. Okay, usually your patients would start with light or mild pain, but eventually, if the perfusion would be cut off, if necrosis would set in, the pain would be more severe. So patients who have this problem should undergo surgery if needed. Okay, so it's a medical emergency. You just don't give the patient pain reliever, send them home. You have to evaluate properly, right? So what to ask in patients if you suspect PAD? So intermittent claudication or pain, cramping in the leg during exertion, which is relieved by rest, coldness, numbness, pallor in the legs or feet, and loss of hair over the anterior tibial surface. So these are the questions that you have to ask your patient. So again, pain or cramping in the legs during exertion, that is relieved by rest within 10 minutes. That would be your intermittent claudication. So again, relieved by rest within 10 minutes. So what to ask your patients if suspecting for PAD again? The two common types of atypical leg pain on exertion and at rest, and leg pain or carry on. So we will discuss that. So leg pain on exertion and at rest, this would be your exertional pain that can begin at rest. And your leg pain or carry on would be exertional pain that does not stop the patient from walking. So your patient can still go on. So you ask specifically about the PAD warning signs that follow. So particularly in patients more than 50 years of age and those with PAD risk factors, especially smoking, like I've mentioned earlier. Then also patients with diabetes, hypertension, elevated cholesterol, African American ethnicity, or coronary artery disease. So if your patient has those, so they would be at risk or at risk for PAD. So when symptoms or risk factors described in the next box are present, you pursue careful examination and testing with the ankle brachial index. We will discuss how to do that. So the ABI. So peripheral artery disease warning signs. So what you should be mindful when doing your history taking and physical examination. So first would be fatigue. Patient would be fatigued, aching, numbness, or pain that limits walking or exertion in the legs. If present, identify the location. Ask also about erectile dysfunction, any poorly healing or non-healing wounds of the legs or feet, then any pain present when at rest in the lower leg or foot, and changes when standing or supine. So ask your patient if you're standing or supine, is there pain? If you're sitting down, especially if you're not moving, do you feel pain also? So you have to distinguish. Also ask abdominal pain after meals and associated food fear or weight loss. So maybe when they eat, pain would be felt in the abdominal area. That's why patient would not want to eat or does not want to have food intake. So also have any first degree relatives with abdominal aortic aneurysm. So if patients would have relatives with AAA, then patient would be also of high risk. Okay. So earlier I mentioned about hair loss over the anterior tibia. This would describe a decrease in arterial perfusion in that area. Then okay, here. So only 10% of patients have the classic feature of leg pain with exertion relieved by rest. Another 30% to 50% have atypical leg pain and up to 60 are asymptomatic. So asymptomatic patients can have significant functional impairment that limits or slows walking to avoid symptoms as PAD is progressing. So patient will just adjust. Maybe they will not know that they have the symptom or they have the condition already. Then location and sites of ischemia. So symptom location suggests the site of arterial ischemia. So for buttocks and hip, so the location would be aortoiliac, erectile dysfunction, iliac pudendal. Thigh would be from the common femoral and aortoiliac. Upper calves would be your superficial femoral. Lower calf would be popliteal, and foot would be in the tibial or peroneal area. So these symptoms suggest um, so prevalence, again, earlier I mentioned about AAA. So prevalence of AAA in or your abdominal aortic aneurysm in first degree relatives is 15 to 28%. So it's still significant. Although it's not 50%, but still 15 to 28% is significant if you have first degree relatives. Okay. So symptoms and site of ischemia. So next we go to venous thromboembolism. So in patients with central venous catheters, ask about arm discomfort, pain, paresthesias, and weakness. Also ask about pain or swelling in the calf of or legs. So these symptoms point to upper extremity DVT. So if you have pain, arm discomfort, paresthesias, and weakness, so upper extremity DVTs, because most commonly these are caused by catheter-associated thrombosis. So if patients have venous catheters or central CVPs, you ask about the those symptoms. Most patients are asymptomatic with thrombosis detected on routine screening. Then for pain or swelling in the calf of leg, because individuals should know, or you as a physician should ask your patients regarding pain or swelling in the calf of legs, because patients would mostly would not or would disregard that symptom. So they might think that it's just muscle spasm, it's just something else, maybe prolonged standing, prolonged walking. But you as the physician should ask if they have pain in those areas so that you would suspect. It will not mean that it will diagnose right away, but you would suspect the patient to have deep vein thrombosis if patient has those. So that would be a differential diagnosis in your part. Okay, I think we're halfway to our lecture, so let's have a 5 minute break. Okay, 5 minute break, then we'll continue with health promotion and counseling. Okay. So everyone in online, let's have a 5 minute break.
Yes, doc.
Yes, doc.
Thank you. Okay, let's start. So for everyone online, we'll be continuing the lecture. So now we've reviewed anatomy, we've reviewed physiology. Let's go to health promotion and counseling. So we will counsel our patients. We will talk to our patients why it is important to do or to take care of their body. Why is it important to know the different signs and symptoms of these conditions in the peripheral vascular system? And we should know how to promote health and how to counsel them if they already have the disease. Okay, so as physicians, we just don't treat the disease, we just don't give medications, but we have to know how to prevent the disease from our patients. We have to know how to keep our patients healthy. Okay, so we don't wait that our patients would get sick before we do intervention. So if you go back to your country, if you go back to the place where you want to practice, try to promote health. So we just don't give out medications, but we keep our patients healthy. Okay, we don't want our family members, right, to get sick. So we have to give them vitamins. We have to give them. We have to ask them to exercise. So health promotion is still very important. Okay, so health promotion and counseling. These are the important topics for promotion and counseling. So screening for lower extremity, peripheral artery disease. We will be tackling on the ankle brachial index, explaining how to do it. Then screening for renal artery disease, screening for abdominal aortic aneurysm. Because of its high prevalence, we have to screen as early as we can to prevent complications in the future. So first, screening for lower extremity, peripheral artery disease. So as we all know, atherosclerotic lower extremity PAD affects more than 200 million people globally. So prevalence increase with age, ranging from 5% at the age of 40 to 49 years old to 15 to 20% in persons aged 80 years and older. So as we grow older, the incidence would increase. Cardiovascular risk factors, particularly smoking and diabetes, would increase the risk for PAD. So an estimated 40% to 60% of PAD patients have coexisting coronary artery disease and or cerebral artery disease. And the presence of PAD significantly increases the risk for cardiovascular events. So only a minority of PAD patients have classic claudication, and many are asymptomatic. So that's why we have to screen as early as we can. So risk factors. Risk factors for lower extremity PAD would be, as mentioned, age more than 65 years old, age more than 50 if your patient has history of diabetes or smoking. Then leg symptoms with exertion, as discussed earlier. So ask your patients if they move around, if they walk, do they have pain, numbness, and other symptoms. Then you should examine also non-healing wounds. So patient would tell you, doc, I have this wound a few weeks or a few months already. Maybe because I'm just diabetic, that's why I have the wound. But yes, it would be a cause, but still, why is the wound not healing? Because of your poor circulation. Then maybe patient also has poor hygiene. So patients would with hypertension, with diabetes are also risk factors, right? So that's why we have to screen properly. Again, patients more than 65 would be a risk factor. More than 50 if with history of diabetes and smoking, with leg symptoms upon exertion and non-healing wounds. Okay, you have to take note. Then we go to the ankle brachial index. So PAD can be diagnosed non-invasively using this, the ABI. So ABI is a ratio of blood pressure measurement in the foot and in the arms. Values of less than zero point 0.9 are considered normal. So later, we will be discussing the formula, just an overview. Then this is used because it is reliable, reproducible, and easy to perform in our office or in the clinic. Okay. So although the sensitivity of an abnormal ABI is low, which is 15 to 20%, the specificity is still at 99%, and the test has high positive and negative predictive values, both at more than 80%. So it's still reliable. Clinicians or office staff can easily measure systolic blood pressure in the arms using our BP apparatus or our sphygmomanometer. Then the quigal pulses using a Doppler ultrasound. So if your clinic is capable, you have a Doppler ultrasound, then you can do this. So these values can be entered into a calculator available, which is seen in the websites. Then you can compute already for the value of your ABI. Okay, for a while. So in my slide, this would be how to measure your ABI. So this can be found if you're again following the book or your ebooks. It can be found in the later portion of the chapter. Okay, so this would be the instructions for measuring the ankle brachial index. So first, patients should be rest supine in a warm room for at least 10 minutes before testing. So that patient will have no increased blood pressure or anything like that. So as also when you get your blood pressure for your patient has to rest, not from walking, not from climbing upstairs. Patient has to rest before you get the blood pressure, right? So place the blood pressure cuff on both arms and ankles, as illustrated here and in the next picture. Then apply ultrasound gel over the brachial, dorsalis pedis, and posterior tibial arteries. Measure systolic pressure in the arms. So use vascular Doppler to locate the brachial pulse. Inflate your cuff 20 mmHg above last audible pulse, and deflate cuff slowly and record pressure at which the pulse becomes audible. So if you use your Doppler, it will make a beeping sound, so you will know. Obtain 2 measures in each arm and record the average as the brachial pressure in that arm. So later I'll be showing a table where you can put your data. Then from that data, you can input it to a calculator. So next is to measure the systolic pressure in the ankles. So you place your cuff like that. Use the vascular Doppler to locate the dorsalis pedis, inflate the cuff at 20 mmHg above the last audible pulse again, and deflate the cuff slowly and record pressure at which pulse becomes audible. Again, obtain two measures in each ankle and record the average as the dorsalis pedis pressure in that leg. Repeat above steps for the posterior tibial arteries also. How to calculate? So this will be your formula. So highest right average ankle pressure, highest average arm pressure, left or right. Then you have your table that you will be putting your results in. Then after that, you go to the calculator. So this will be your ankle brachial index calculator. Then you input your data. So interpretation, a value of more than 0.9 with a range of 0.9 to 1.3 would be lower, normal lower extremity blood flow. A value of less than 0.89 but more than 0.6 would be a mid PED. 0.59 more than 2.4 moderate PED, and severe PED would be less than 0.39. Okay. Recommendations for managing PAD. Again, as we all know, smoking is very one of the risk factors. So tobacco cessation is very important. Okay, so tobacco cessation is very important. I know it's very difficult to ask your patient to quit smoking right away. So there are programs on how to stop smoking. You can enroll your patients on that program. You, if you're smoking right now, maybe you can start or try to contemplate on quitting smoking. So tobacco cessation is very important in our patients, especially in elderly patients who have hypertension, who have diabetes. If they are still smoking, then they would get complications, more complications than us. Then treatment for hyperlipidemia. So patients should go on treatment, should have monitoring every 3 months or every 6 months to check if their lipids are going low. Then optimal control of diabetes and hypertension. So patients again should have monitoring on their blood sugar, on their blood pressure. They should know how to monitor themselves, check for capillary blood sugar, check for BP. They should have someone at home to monitor that. Then use of antiplatelet agents if necessary. Then meticulous foot care and well-fitting shoes, especially for diabetic patients with PAD. They should know how to take care of their foot. So maybe when you check, the foot is clean, no wounds or anything. But behind the callus, behind the thick skin, there are already necrotic tissues that we do not know because we did not assess properly on the sensation of the patient. So diabetic foot exam, if you can search that in YouTube, so it will show you how to properly assess the foot, especially sensation, pain sensation in the foot. So you will know if there is decreased sensation, decreased circulation, and everything. Next would be screening for renal artery disease. So atherosclerotic renal artery stenosis presents in substantial proportions of patients with the following: end-stage renal disease patients, congestive heart failure, co-occurring diabetes, hypertension, as mentioned, then other atherosclerotic diseases. So the guidelines would recommend duplex ultrasonography, magnetic resonance imaging, and CT angiogram. So you would suggest to your patients, if you're suspecting for renal artery diseases, so you would suggest these screening methods. Although they are expensive, but if it is really needed, then you should try to convince your patients how to or to get the screening. So these are conditions suspicious for renal artery disease. So onset of hypertension less than 30 years of age. So young individuals who have hypertension at an early age should get screened. So it's very unlikely for us. I think I'm still I'm still at the 30s. So onset of hypertension at a younger age, you should have your patients screened, especially if they also have relatives who have hypertension at a younger age. They have higher risk. Then onset of severe hypertension at the age of 55, meaning the patient is still taking medications but it's poorly controlled. So maybe patients have a problem with a renal artery disease. Then accelerated, sudden and persistent worsening of previously controlled hypertension. So accelerated, resistant, or malignant hypertension. So meaning even though you're taking a lot of medications, there is still poor control or there is a sudden spike of your blood pressure. So again, you have to be suspicious and have your patient screened. Then new worsening of renal function or worsening function after use of an angiotensin converting enzyme inhibitor or an angiotensin receptor blocking agent. Then unexplained small kidney or size discrepancy of more than zero point 0.1 cm between the two kidneys. So upon an ultrasound or upon CT scan, there are discrepancies in the sizes of the kidney. So maybe your patient has this. Sudden unexplained pulmonary edema, especially in setting of worsening renal function. So end-stage renal disease patients would have this condition. So when your patient asks you, Doc, why are you asking me to have this exam or have CT scan, have MRI and all those things? Maybe you can tell your patient, maybe you are at risk because you have these conditions. Okay. Then you can also tell them on the prevalence of the condition, why is it important to screen. So for AAA, abdominal aortic aneurysm defined as an infrarenal aortic diameter of more than 3 centimeter. Okay, remember, more than 3 centimeter. It might come out in the exam. Prevalence, older than 50 years of age. Men have a higher prevalence than women. So 3.9 to 7.2% compared to women, which is 1 to 1.3%. So mostly would be big, stocky men, abdominal pain, comes to the ER, then suddenly dies. Maybe ruptured abdominal aneurysm. So that would be a condition that you should look out for. And maybe patient comes to your clinic, abdominal pain, and you do palpation. You don't know it's an aneurysm. Maybe you can do damage. So be careful. So rupture, this is a dreaded consequence of the AAA. Risk is increased when aortic diameter exceeds 5.5 centimeter. So our aorta has a limit. So more than that, it's just like a hose or a balloon. If you put too much pressure on it, it will burst. Yeah. So the elasticity of your aorta has a limit. So more than 5.5 cm, it will be a higher risk for rupture. So let us be careful. Also, when you do your abdominal examination, be sure you know what areas you are palpating, right? You do deep palpation where lower quadrants because you want to check for your appendix. You want to check maybe kidneys. So be careful when doing deep palpation, when doing procedures to the abdomen. Risk factors for AAA, again, old age, male, again, smoking, and family history. So if your patient has relatives, especially first degree relatives, so ask them to go or have screening. Then other potential risk factors, cerebrovascular disease, atherosclerosis, hypertension, and hyperlipidemia. That's why we should control our patient's medical condition. Control hypertension, control hyperlipidemia, if possible, decrease, prevent atherosclerosis from happening, so that we can prevent AAA from also happening. So now that you have discussed with your patients the different conditions and the risk factors, then we go to the techniques of examination. Okay. So techniques of examination, this would be the time that you're done with your history taking, you're done counseling your patient. Now you want to find out if what you are thinking, your differentials are true. So now you do your physical exam. So these are the important areas of physical examination. So for physical examination, you want to check the arms, the abdomen, and the leg for this particular system, for the peripheral vascular system. So for the arms, you check out the size, the symmetry, skin color, rapid pulse, radial pulse, brachial, epitrochlear lymph nodes, because we want to know if there are infections in the hand. Then for the abdomen, you have aortic width and pulsation, inguinal lymph nodes. Then for the legs, again, the size, the symmetry, skin color, femoral, popliteal, dorsalis pedis, posterior tibial pulses, as we have mentioned. Check for the thighs, the calves, ankles for any swelling and edema. Okay. So why is it important to check the size? So size maybe for poor circulation, poor development, poor growth of your extremity. Symmetry, maybe one side is occluded, the other is not, or maybe there is swelling in the one side is just normal. So check for symmetry. Skin color, again, poor circulation, maybe hair loss or pigmentation if pallor. Yeah. So that's why. These are the important areas to examine. So key components of the peripheral arterial examination, again, measure blood pressure in both arms. So proper measurement of the blood pressure, step by step, okay? So when we have our return demo in the future, you're informed, right, that you have a return demo? No? So in our SGD, at the end of the semester, so aside from the SGD, everyone is expected to come to campus. So you will have a return demo on the different techniques. It will be a one-on-one demo. So you will be doing a demonstration in front of the facilitator. You'll be asked different techniques, maybe blood pressure taking, maybe how to do abdominal examination, how to do the different tests. So for this one, you have to know how to properly take the blood pressure, how to use your stethoscope, your BP apparatus, how to position patients and everything. So you have to know that. Okay. So that's the importance during SGD, small group discussions. If you are asked how to do the technique, you should discuss within the group so that everyone will know the proper technique, the proper step-by-step way to do the technique. Okay. So palpate the carotid upstroke, auscultate for bruits. You auscultate for aortic, renal, femoral bruits. So try to listen and try to also watch on YouTube. There are different or good videos. You can listen to your own self or your classmates for normal sounds. Then try to correlate it with the abnormal findings. Okay. Then palpate the pulse of the brachial, radial, ulnar, femoral, popliteal, dorsalis pedis arteries. Inspect the ankles, feet for color, temperature, skin integrity, as mentioned. Note any ulcerations, hair loss, skin changes, and hypertrophic nails. Okay. Then when you record your findings for the pulses, you have to know how to grade them. So there are different types of grading, but what we use here in PD based on the book is would be the 0 plus 1 plus 2 plus 3 plus grading. So you have to know what is 0, what is 1, 2, and 3, right? Then if you know, you have to check also different people, try to feel their pulses if they are a 2 or if they are a 3. Okay, so maybe if one person runs, check your pulse, it's bounding because of the increased pressure, increased heart rate. So that's a 3 plus. If you're at rest, normally it's brisk 2 plus. I don't know how to get a 1 plus or a 0, but um, okay. Can you hear me? Okay. See. No more butters. Got tired. Okay, I hope this microphone. Okay, so for a patient who is at shock or maybe possibly dying, so maybe you will not be able to palpate the pulses. So absent or unable to palpate, you would grade that as a 0. If it's diminished, weaker than expected, especially for patients who are on severe dehydration, right? For severe dehydration patients, we have lower blood pressure. The pulse would be weaker, so that would be a 1 plus. Normally, it's a 2 plus. And for patients who are maybe from physical activity, patients who are mild dehydration patients where the body is trying to compensate, so heart rate becomes higher, the pulses will become stronger. So you have to know what is bounding, what is brisk, what is diminished, and what is absent. Okay. So how to do physical examination? First, inspect your patient. Don't do palpation right away. Don't do auscultation and percussion right away. First, inspect your patient. Check your patient. So again, both arms, fingertips to shoulders. Check everything. If your patient is wearing a shirt, try to ask your patient if it's possible to remove the shirt. And if it's a female patient, if you remove the shirt, try to put a drape on the patient. Okay. So you note any size, symmetry, swelling, venous pattern, color of the skin, color of the nails, and texture of the skin. Also hair distribution. Try to assess that also for inspection. Also, when you do your inspection, it has to be both arms, both legs, whole abdomen. Okay, not just one arm, not just the other leg, but both. Then, if you're inspecting also, not just the arm and legs, you can include the axilla and the sides and the back, the chest. So, it's dead. Okay, so try to include everything when you do the inspection. Then for palpation, so for the upper extremity, you palpate the radial pulse within the pads of the finger on the flexor surface of the lateral wrist. Then compare the pulses in both arms. So if they are the same in intensity, plus 2 plus or 3 plus, or maybe one is lower, one is more pronounced. Okay. So also distinguish if it is the patient's pulse or yours. So be careful, huh? You might be counting like that and you're counting your pulse, not the patient's. Okay. Mind you, there are really instances where your pulse is stronger than the patient's. Yeah, especially if for patients who are at shock, like extremely dehydrated, hypovolemic shock patients where the pulse is weak. There are instances that it's your pulse that you are feeling. Oh.
We can
It-
do the online class.
Huh?
I did check the online class.
Yeah, it's okay. So online people, can you hear me?
Yes, sir.
Yes, Doc.
Okay. Yeah, the microphone here is okay. So yeah. So for radial pulses, try also when you palpate, try to position yourself in a way that you are not you don't have difficulty. Like you should be sitting down or standing up. Patient should have hands resting so that you will not have a hard time feeling that pulse. So because if your patient is in an awkward position and you're trying to palpate the pulse, maybe you will miss out on that particular area. Then maybe you will say pulse is just +1 or 0, where actually you're not palpating it or locating it properly. So that's why you have to be careful. Then, so if arterial insufficiency is suspected, palpate the brachial pulse. Then flex the patient's elbow slightly, palpate the artery just medial to the biceps tendon at the antecubital crease. So can also be palpated higher in the arm in the groove between the biceps and the triceps muscle. So if you cannot feel it in the distal, go proximal, then palpate the different areas. Okay. Try as much as you can. If you have a patient with weak pulses, try to feel all the possible areas that you can feel the pulse. Don't go directly from here. You can feel the pulse. You go directly to the jugular. Okay. So try to follow. If you can feel it on the one side, try to go to the other side. Okay. Then also, physical examination. You can also palpate again your epitrochlear node, especially if you are thinking of possible lymph obstruction or infection. So how to do this? Elbow flex to a 90 degree. Support your patient's forearm by your hand. Then reach around and behind the arm and feel the groove between the biceps and triceps muscle about 3 centimeter above the medial epicondyle. So try to feel that. If your patient has infection or lymph nodes which are inflamed, they will feel pain. And you as the physician would feel the mass. For us, it's not really felt because we don't have the pain and because we don't have infection, we don't have occlusion. Okay. So also ask your patients if they have felt it also previously at home when they do physical exam on themselves. Do they feel pain on that area? Then for the abdomen, this would be a focused examination. You're done with the abdomen, right? Abdomen topic. Yeah, it was discussed last time. Okay. So for this you focus on the aorta. So auscultate for aortic, renal, and femoral bruits. Palpate and estimate the width of the abdominal aorta in the epigastric area by measuring the aortic width between 2 fingers. So especially the older adults and smokers, they would have a larger, right? Because of the distension. Then always assess for pulsatile masses. So if you have an aneurysm, it would be more pronounced. Okay. Then you go to the inguinal lymph nodes. Again, try to locate them properly because if you do not know their exact location, you will not be able to palpate them. The superficial inguinal nodes, including the horizontal and vertical groups as mentioned earlier, you have to locate and palpate them properly. Take note of their size, consistency, discreteness, and tenderness. So ask the patient properly, or maybe ask them for if they will allow you to palpate on that area, and tell them that you'll be palpating deep or like you will be exerting pressure on that area because they might be surprised why you are poking on that area in their inguinal. So after that, you go to the lower extremities. So patient is supine. Don't forget to drape the patient. Legs would fully exposed. Stockings or socks should be removed when you do this exam. So first, inspect both legs from the groin and buttocks to the feet. So again, from that area going down, and make sure you do it on both extremities. Note the size, symmetry, any swelling or edema. Venous pattern and venous enlargement should be noted, especially patients who have what do you call that? Those varicose veins. Yeah. Then pigmentations, rash, scars, and ulcers. Color and texture of the skin, nail beds, distribution of hair on the lower legs, feet, and toes. So any ulcerations in the foot, any like markings or previous scars, yeah, you should ask your patient what happened to that. Microphones. So upon inspection, you can ask your patient again what happened to that extremity. Also, when you do your physical examination, maybe you're thinking that I'm doing physical exam, I'm not gonna talk to the patient anymore. It is really okay to talk to your patient, ask them again further information, further history regarding their condition while you are doing physical exam. Number one, it will give you more information. Number two, it will keep also the patient at ease so that they will know what you are doing. Maybe they will know or understand that you are finding more information while doing the physical exam. Okay. So inspection, color of the skin. So local area of redness. If you have that area of redness, you note its temperature. Brownish areas near the ankles, any ulcers in the skin and the location. So ask the patient to stand and inspect for varicosities. Check for thrombophlebitis. Compare both thighs, calves, and ankles for symmetry. Okay. So it's very important, again, to check for symmetry. So relative size, prominence of veins, tendons, and bones. So ask your patient, do you have any history of polio infection? If there are any changes or any differences in the size. If none, so maybe patient has other conditions, maybe PEDs or any circulatory problems, right? Then, if you have swelling or edema, check if it is unilateral or, thank you. Check if it is unilateral or bilateral. So note for the extent of swelling. So if unilateral swelling is detected, you measure the calves 10 cm below tibial tuberosity. Normally, it is the difference would be less than 3. So if the difference between the calves is more than 3 centimeter, so there is unilateral swelling. Okay. So if both feet are swollen or edematous, then when you measure them, it is less than 3. So that's bilateral. Okay. So palpation, peripheral pulses that you should be able to palpate. So you should locate the femoral pulse, popliteal, and your pedal pulses. So for the femoral pulse, again, please ask permission from your patient. You press deeply below the inguinal ligament and about midway between the anterior superior iliac spine and the symphysis pubis. Then, as in deep abdominal palpation, use 2 hands on top of each other, especially in obese patients. But some patients would have a strong bounding pulse, so when upon light palpation, you can already feel the femoral pulse. Okay, just make sure that it's the patient's pulse, not yours. Maybe when you do that, okay, I can feel the pulse, but it is yours that you are feeling because you are anxious because it's your first time to do palpation in a very pretty patient. So you will have difficulty distinguishing your pulse and your patient's pulse. So be sure also to how to check that if it is yours or the patient's. You can auscultate the patient's heart. if it coincides with the pulsation, okay, the rate, not yours. So that would be one way to check it. Then your popliteal pulse, patient's knee should be somewhat flexed with the patient's leg relaxed. So ask the patient to relax the leg. You'll be the one to support the knee. So place fingertips of both hands so that they may just meet in the midline behind the knee and press them deeply into the popliteal fossa. So try to deeply palpate that area. Popliteal pulse may be more difficult to find in than other pulses, but uh, it is pronounced when you do it properly. So again, check the image. That's how you should be doing it. Please don't forget to drape your patients up. Okay. So if you cannot palpate the popliteal pulse with the previous approach, try with the patient being prone. Flex the patient's knee to about 90 degrees. Let the lower leg relax against your shoulder. As a physician, you'll be standing. You'll be assessing. Then press your two thumbs deeply into the popliteal fossa. So if you do it properly, you'll be able to feel that pulse. Then your dorsalis pedis, palpate the dorsum of the foot, not the ankle. So just lateral to the extensor tendon of the great toe. So the deep dorsalis pedis artery may be congenitally absent or branch higher in the ankle. So if you cannot feel it on that area, try to move up or try to locate it. So not right away everyone can feel their pulses in that area. So you have to explore the foot and try to palpate it. Then your posterior tibial pulse. So you curve your fingers behind and slightly below the medial malleolus of the ankle. So this pulse may be hard to feel in a fat or edematous ankle. So that's why check if your patient has edema. So it would be expected that it would be difficult. But if your patient does not have edema and it is absent, so maybe there is something wrong with your patient. So try to locate it properly. Okay. Last 2 minutes. Sorry. So assess the temperature of the feet and legs using the back of your fingers. So temperature, you can use your hand. If there are bilateral coldness, maybe due to environmental factors or anxiety, try to assess properly. So for difficult pulses, again, I mentioned earlier, position your body, examining hand comfortably. So awkward positions may decrease your tactile sensitivity. That's what I mentioned earlier. So you have to be in proper position. So linger and vary the pressure of your fingers to pick up a weak pulsation. So you have to explore, find the pulsations, and try to practice so that you will pick up weaker pulses. Then do not mistake the patient's pulse with your own pulsating fingertips. So if needed, count your own heart rate compared to the patient. So you will have the proper, you can discriminate from yours and the patient's. So these are just conditions where circulation is poor. So chronic arterial insufficiency, you have this condition. Chronic venous insufficiencies, you have these, the painful ulcers. Then peripheral veins. So try to check over the dorsum of each foot behind the medial malleolus, over the shins. Look for pitting, so edema. Palpate venous tenderness or cords, inguinal area just medial to the femoral pulse for tenderness of the femoral vein. So when you do arterial palpation, try to also palpate the other areas in that part to check for venous, the peripheral veins. Okay. And arterial perfusion of the hand. These are special techniques where you can also check in the book and check at YouTube how to do this. So palpate the ulnar pulse like that. So press deeply on the flexor surface of the medial wrist. Partial flexing of the wrist may help because you can feel the pulse better if you partially flexed it. Then you have your Allen's test. So Allen's test compares the patency of the ulnar and radial arteries. So you can check for perfusion when you do the test. I hope you will check this in the book and in YouTube. So how to do this is you occlude both arteries, then ask the patient to open their hand. When they open their hand, you release one blood supply and you will see reperfusion and check if it is patent or normal. So upon releasing, you have good perfusion. So about 3 to 5 seconds, it reperfuses. Then postural changes of chronic artery insufficiency. So Berger's test. So raise both legs 90 degrees after 2 minutes until there is maximal pallor in the feet. Then light skinned persons will have normal color, and you check for discrepancies. If one leg is darker or lighter, check for perfusion. So also ask the patient to sit up with legs dangling, compare both feet, noting the time required for the patient to have reperfusion. So return to pinkishness to the skin normally about 10 seconds or less. So if more, maybe perfusion is not good. Okay. Mapping of varicose veins. You just check if you occlude one area and the other area, if there are pressure building up or you can feel the fluid wave. So maybe that is the same supply. So that's how we map it. Okay. So Trendelenburg test. So competency of your venous veins. So you use to assess volumes of the communicating veins and saphenous vein. How to do this? Patient is supine. Elevate one leg to 90 degrees to empty to empty out your venous blood. Occlude the great saphenous vein in the upper thigh by manual compression, using enough pressure to occlude this vein, but not the deeper vessels. So ask the patient to stand. Then while you keep the vein occluded, watch for venous filling in the legs. Keep the vein occluded, okay? So don't release it yet. Normally, the saphenous vein fills from below, taking about 35 seconds of blood flow through the capillary bed into the venous system. Then after the patient stands for 20 seconds, you release the compression and look for sudden additional venous filling. So while you're still occluding it, there is perfusion already. Then when you release it, look for additional filling. So normally slow filling continues because competent valves of your saphenous vein block retrograde flow. So there is no backflow. Okay. Then lastly, record your findings properly. You can check your book how to record your findings. Okay. So the pulses, right? 2 plus 1 plus 0. Then if there are any skin changes, color changes, asymmetry, you have to note them. Okay. Then these are my references. So it's the one we use. Exams will be taken from this. Read your book. Maybe we can have the PowerPoint. Maybe I can give it to you. I'll just ask Dr. Miranda first. But basically, we use the book for our reference. Okay. So if there, that would be my lecture. Thank you so much. If you have questions, any questions from the group? None?